Right, well, good afternoon, everybody. It's 2 o'clock, so welcome one and all to the Health and Adult Social Care Overview and Scrutiny Committee. Before we start these proceedings, may I bring your attention to some of the housekeeping matters. There's no expected fire alarm today. Therefore, if the fire alarm sounds, please follow the fire and emergency procedures that are applicable to the council house. This meeting is being broadcasted live to the internet and will be capable of subsequent repeat viewing. By entering the Warspite room today, you are consenting to being filmed throughout the meeting and to the use of those recordings for webcasting. Please can I ask that you speak clearly and directly into your microphone when addressing the meeting so that the online participants and the public can hear, and that it is switched off when you're not using it. Mobile devices should be turned to silent, please. Now, what we've got today is the topic of today is primary care, and that is looking at general practice and pharmacy. We know that Plymouth's health and care system is undergoing significant changes, and the impact of COVID-19 is still being felt and impacting on all our partners. We appreciate the effort of all staff who have and continue to work in this challenging environment. However, it cannot be ignored that there are ongoing issues with service provision and attainment. While many of us have passionate and emotional experiences with these shortfalls, we as a committee must endeavour to constructively engage with health staff to examine service issues, remedial measures and future opportunities, producing recommendations and a drive for improvement on behalf of both health workers and the residents we represent. So, we will get on with the meeting. Do we have any apologies? I think they're all here actually, aren't they?
Yeah, no apologies today, Chair.
Thank you. Right. Declarations of interest. Have members got any declarations of interest in respect of the items on the agenda today? Natalie.
Thank you, Chair. I have a personal interest. My partner's a patient at Beacon Medical.
Thank you. Right. The minutes of the meeting that took place on the 13th of July. I know that was quite a while back. Are you happy that they're a reasonably accurate record? Nobody telling me they aren't? They are, I know, that's what I'm saying. They are an accurate record. All right, we'll agree on that. So can I have a proposer for that? Thank you, David. And a seconder? George? Thank you. So I will then sign accordingly when I get a spare couple of minutes. Chair's urgent business. There's a couple of bits and pieces on this one, please. Anna, has anybody warned you that I was going to ask you about if we could have a quick update on delayed transfers to care? Because I know that was something that has been in the news and we were concerned about.
Thank you, Chair. Yes, I did have a little word of warning, and you'll be pleased to know that also delayed transfer of care numbers is something which I can pretty much recite on a daily basis at the moment. So in terms of today's position at University Hospital Plymouth, the average length of delay for Plymouth is at 8.9 days. For Devon, it's at 4.5 days. And for Cornwall, it's at 22.4 days. I can advise, Chair, that this morning I met with colleagues from the system with the National Discharge Task Force, where we particularly highlighted the challenges in terms of the Cornwall position, which is both within their healthcare services and social care services in terms of those delays. We have a target but I think from the last time that we were here, certainly we're seeing significant improvement. Unfortunately, our Cornwall colleagues have a target of 8 patients delayed. Today they are currently reporting 54. So I think, you know, Chair and committee, you know, the pressure in the hospital continues. What I would say is that from the last time we hear, the partnership working and the priority, and there definitely are some green shoots of improvement from a Plymouth perspective, but clearly the impact on the trust of the Cornwall position is a cause of concern.
Thank you very much indeed. And obviously, there's all we can do is say, you know, we hope everything starts to go down that route that we're hoping it is, and certainly it's something we'll keep an eye on. You feel for Cornwall, don't you, trying to get all of this sorted, and that's putting that extra pressure on. So thank you. George, yeah.
Could we ask for an explanation? I mean, well, I suppose we all know what it is, but could we ask for some further details of the position at the next meeting?
I think this is something we will keep an eye on. I think it's something that we will keep very much on our agenda, because that makes a lot of difference to what's happening. So yes, I'm sure Anna will be able to keep us updated on that. And whilst we can't influence what's happening in Cornwall, of course, we can just make sure that we in Plymouth are keeping as much on top of it as possible. So thank you very much for that. The next thing I wanted just to mention was that following your motion on notice at council on the, I want to say the 20th of June, about the basically the concerns about the ambulance delays, etc., that Councillor Lang brought, I did send a ministerial letter, or a letter to both the Prime Minister, the Secretary of State for Health, and we've now had a response to it. So because it came from a full council meeting, I will be asking the officers to share it with all councillors, because that's it's not just something that in our remit, but had a letter. So it's quite a long letter, so I do not plan to read it out, but we'll get it circulated to everybody, all right? Whether it actually answers the question that motion on notice sent is a different matter, but that's for you to make your mind up. Okay, so there's that one. The other letter I wrote was about concerns about dental things in Plymouth. We have been having a real big problem of getting answers on certain basic things to me, like how many are on the dental waiting list and such forth like that. I did send a strongly worded letter, I think we will say, to the head of the dentistry provision within the NHS in the Southwest, saying that if I had no response by today, we would be calling dental services in for a scrutiny. Can you bet on what's happened? I've had a holding email this morning to say they will be addressing those issues, but as such, I have got no response. I am putting a motion on notice at council on dentistry. So what I'm going to propose that we do is in October hold a one-off scrutiny on dentistry within Plymouth, and we get all those issues that I've got addressed. So as soon as I get any response from that letter, I will let you know, but as of yet we haven't, which is disappointing, but we'll take it from there. Okay, folks, so just really to update you on that. Right, I shall now move on to the next item, which is Sarah Gooding and the Health and Adult Social Care Policy Brief, which you've all had. And just really to ask you, if Sarah wants to make an overarching comment about it, and then if there's any questions to ask her, we'll do so. Okay, so Sarah, the floor is yours.
Thank you, Chair. Sorry, I'm trying to turn my camera on, but it doesn't seem to be working at the minute. Oh no, there we go. So this is just a roundup of government announcements since the last scrutiny session in July. Not an awful lot, mainly due to the time of year, but just to point out, the Women's Health Strategy was published in July, and also there's been some guidance issued around integrated care strategies and how scrutiny committees can work with the new system of integrated care partnerships, which has come from the Health and Care Act. I don't know if anyone has any questions for me.
Sue?
If I talk on the women's health strategy within the document, I noticed that pre-pandemic, women in the northeast were showing a dip in health status, and they were dying and mortality rates. I see what the strategy is about, but what I'd like to know, are there still regional differences in terms of women's health across the piece, as it were? I mean, where we're seeing the impact of recession, it's likely, unless money around, I'm wondering if that's going to have, well, it probably will have an impact upon health and well-being of women in particular, and that's, you know, what is the government's first ever women's health strategy for England. And I just wondered what the state of it is now.
Can I just, I don't know whether Sarah can answer us on that, but the next scrutiny meeting that we have in November will be dedicated to public health, and I've already asked the Director of Public Health to make sure that we are updated on our health indices, because we haven't had that for a long time, and certainly Sue, that's one of those things that we will be looking at in very much detail related to the city particularly.
Thank you, Chair.
Ian, you've got something.
Thank you, Chair. It's on the item marked NHS staff to receive pay rises. And I notice as it goes on that eligible dentists and doctors will receive 4.5% pay. Now, we're all aware of the crisis in dentistry, particularly in our area. And this is, in actual fact, a pay cut with inflation running at God knows what at the moment, but certainly in double figures. And perhaps I'm just making a comment rather than asking a question, but it seems to me that this is not going to help the situation in either doctors or dentists. And it goes on to say, while balancing the needs to protect taxpayers, manage public spending and not drive up inflation. But inflation's already with us. And it seems to me the wrong direction of travel when we've got a crisis in dentistry to be giving people pay cuts. And I just wanted to make that point. I understand the officer's not in a position to answer that as a question, but I appreciate the opportunity. Thank you, Chair.
Can I suggest you store that when we do the dental scrutiny? That would be quite a useful thing then to put, because I understand that the contract is being reviewed at the moment, the dental contract. So that might be something that they know a bit more about in October. Anybody else got any comments? I suppose really it'll, Sarah, the saying that there's health and wellbeing boards, there's some guidance for engagement, so that'll be very useful for those of us that sit on the health and wellbeing board. Presumably that's something that will be coming to us for perusal quite soon, so that's good. And guidance on the preparation of integrated care strategies. Any sort of further anything there, Sarah, that you can help us add to that? Is the exciting document for us to read?
This is just, I think it's some core principles, and the actual statutory guidance will be released further down the line. But I did a briefing for the last Health and Wellbeing Board session on some of the new measures under the Health and Care Act, including the integrated care strategies. And what this means for health and wellbeing boards and for scrutiny committees. So I could share that round, which I think that would be useful.
That would be great, thank you. And I'm going to dump Craig in it now because it's saying about the Better Care Fund policy framework. And obviously, Craig, that's something that will be needing to be looked at by this committee.
So that one goes to the Health and Wellbeing Board Chair. That's the sign-off route for that particular one.
So can we
But we
have
can
a little bit of
absolutely
look at
circulate
it? Yes,
yeah.
please. That would be really interesting, I think. Well, perhaps that's me being sad saying it'd be really interesting, but still. Anybody else got anything they want to bring? No? Okay. Sarah, thank you very much indeed for joining us. Much appreciated. And as usual, we'll say to any of the committee members, if they have anything that they want to raise with you about policy, that they will get in touch with you. All right? Thank you.
Thank you, Chair.
Right, then I'm going to go over to Ross Jago now, because you'll see we've got 2 item 5s in your agenda, and the second item 5 is talking about risk monitoring report. Ross.
Thank you, Chair. Apologies that you have 2 reports. I think what we're aiming to do is get those amalgamated along with performance reports, so you actually have one agenda item to consider in the future. But while we develop that, what we've provided today is a cut of the strategic risk register with risks pertaining particularly to this committee. So what you have in front of you is the register, which should include some information on the key controls and assurances that are underway. So there's a large A3 sheet which covers the risks. Right, everyone should have that. Thank you. Now, there is 5 risks on the report pertinent to this committee covering health and social care. We have 1 red risk, which is reference workforce, and the remainder cover issues that you all, having been on this committee, will be very aware of, along with so workforce, along with budget, market sustainability, and so on. There is 1 new risk on the risk register concerning adult social care reform, which is a programme of work currently underway, being led by Anna and her team. Chair, I would suggest that absolutely this should be part of your work programme going forward. Considering this risk report is helpful for us because it allows us to give some assurance to the Audit and Governance Committee that risk is being reviewed and scrutinised where necessary at the appropriate body. This is the appropriate body for these risks. I would suggest that you look at adult social care reforms over the coming months, or at least get that onto your work programme, because that umbrella will cover all of the other risks that currently exist on the register. And I might want to have a word about the market sustainability stuff. Thank you, Chair.
Anna or Craig, do you want to come in about market thing or anything to do with this? Honestly.
So I think, as Ross said, the reform programme is now up and running, Chair, and I think having that onto the work programme is really important. In relation to market sustainability, one of the requirements around the reforms is the development of market sustainability plans, and I think it would be helpful probably to have a separate session just to go through those market sustainability plans with yourself and the committee in advance of them being finalised.
And I think if we can work on the time frame for that, and I think, as you say, it may well need to be a one-off session that's, to suit. I think that would be best bet.
I think it will be, Chair. So I think we'll probably, so if you're happy, I'll work with Ross to look at getting that into diaries.
Anybody want to come in on this, Natalie?
The Council is unable to fulfil its legal obligations regarding the safety of its citizens and service recipients. What does that mean? What? I appreciate it's a significant challenge.
I think it's probably yours.
So thank you for the question. There's a number of statutory duties placed on local authorities, and this is the generic one across all council functions as well. So, for example, as Director of Adult Social Services, my duties are quite wide-ranging, and there's always a risk out there that you won't meet those statutory duties as well. So you put in a number of mitigations, and that's what that risk is saying.
through you, Chair, probably should have said it at the start. This is, of course, a risk report. Doesn't necessarily mean that any of these things are actually going to happen. But it's about us considering those possible outcomes and mitigating against them. Most of these are currently amber. We do have one at red, but there is mitigation against that.
When we do budget scrutiny each year, you always see the risk register for the whole council. And I think the last one usually has over 100 items on it of various colours. And that we need to take that into consideration. And I think it's very sensible that we separate it out during the year to those committees that deal with those things, just to remind us, isn't it really, as to where our responsibilities lie and what the RAG rating is doing. You know, I mean, I would hate for any of these amber ones to slip into red, or we pray that some of them go into green. That would be great, but I think it is one of those things. And Craig, with the red one at the moment that we've got there, how are we basically tackling that at the moment? And I appreciate there is a staff concern wherever within social care at the moment, but I just wondering what active things we are doing, please.
So that's been read for a number of months now, Chair, and as a management team and a leadership team, we don't feel unable to bring that down from red at the moment. Hence we've classed it as such. We are regularly tracking that. We still have twice weekly meetings of the management team where we're going through the market to look at where it is, what the workforce initiatives are doing as well. So the board will be aware that we've had lots of workforce initiatives out there. We're actively monitoring cases as well and providers as well, so that we've got oversight of those as well. So there's a lot more greater scrutiny and activity around those providers at the moment, Chair. That's a longer term initiative linked to the fair cost of care exercise to bring that down. At the moment, my view is we couldn't bring that down without addressing the fair cost of care issues, Chair.
Okay, you all happy with that and understand where that's going? Okay, great stuff. So we'll keep an eye on that, and if we need to have anything extra coming out to you, we will make sure that happens. Okay. So is there a recommendation then that we need to follow up on the risk register on a regular basis to see that it's going in the right? So do you want to formulate that for me, Ross, please? You're sending messages down, but with, you know,
too
you're
far
a bit
away
too
from
far
you today.
away, yes.
Too far away from you today, Chair. I think it would be sensible to record a recommendation that you'll continue to receive the risk management register going forward, and that adult social care reform should be added to your work programme.
And if needs be, we will take action or get more answers to questions that we might have. Okay, folks, thanks very much indeed for that, Ross. Much appreciate you coming along, and Craig and Anna, no doubt we will hear more from you. Can I say thank you for making it A3, because we didn't stand a chance when it was A4. Right, so item 6. Welcome, Tony, and thank you very much indeed for joining us again today. It's a real pleasure to have you come along today. And we've asked you to really update us on the experiences that you're receiving from patients and citizens about general practice at the moment. And I just want that to, I know it's not something that haven't got the final report yet, but really getting the flavour of what's happening would be really good for us before we go into a discussion about general practice. So, floor is yours.
Thank you, Chair. Firstly, I'd like to echo Health Watch's sentiment as well around your opening remarks about the system and the staff in the system. I think since COVID, it's certainly been a system under pressure when with changes brought in by the white paper this year. We'll see further changes to how services are delivered moving forward, not just across primary care, but across all aspects of health and social care as well. So I think for us, it's always one of trying to keep up to date with the proposed changes and make sure that there's some messaging that goes out to patients and that around those changes. But I think if I split things into GP and pharmacy as sort of patient views, from a GP perspective, we've seen a marked change into how the services are being delivered, less face-to-face appointments, more around digital, and therefore the sort of feedback we're picking up is around actually accessing services in the first place, but around communication, use of digital systems. E-consult has been one that has been particularly mentioned on several occasions as not being fit for purpose, although there have been changes to that moving forward. And we're actually picking up less issues about e-consult, but it is not an easy system to navigate yourself around. Equally, not every single patient out there wants to use digital systems, and that's not about whether they've got the skill set to do so or the equipment or the knowledge. They fundamentally don't want to do that, and therefore there's got to be a mix in terms of being able to access GP services, and where there is that sort of mix of being able to contact on the phone, or if you want to use online, it seems to be working reasonably well where you're being funneled down one particular route, particularly when the answer isn't necessarily immediately forthcoming. Then patients are starting to complain to us about that. Generally, I think other areas is around communication, so having that two-way communication. I feel people that are managing long-term health conditions aren't always best served at times, and patient safety can be, and in our opinion is starting to be affected by that in some isolated cases, and that's either a misdiagnosis or things not being joined up in terms of treatment plans. We have evidence of that, albeit it's very low numbers. And then the old chestnut, which kind of rolls into the pharmacy bit, is around medication and prescriptions. So we have seen an increase in the number of comments and contacts around pharmacy, and particularly pharmacies in Plymouth, around issues where patients are going to the pharmacy to either collect their prescription or repeat prescription, and it not being ready for them, or they're being told that it's not actually being received by the pharmacy, and they're being left as the person who's being bounced between the GP service and the pharmacy service to get a resolution there. And I think, you know, for me, they've put the script in, or they've had a script raised, and the expectation should be, in due consideration of the time it takes for that to go to the pharmacy, it should be ready for collection when they're told it should be ready for collection, and not being bounced around. The other issue we've seen around pharmacy, particularly in Plymouth, is around some of the national chains where they've had to move staff between sites to provide a service, particularly during COVID, where staff have been off, which has led to short notice temporary closures, and people are just, you know, they're turning up. Some of them have had to drive or make transport arrangements to get to their local pharmacy, or arrange for somebody else to collect on their behalf, only to arrive to find the pharmacy is temporarily closed for a few hours. And other issues have been when they've tried to ring into pharmacies, the phone's not being picked up. If they go to the pharmacy and things aren't ready, they're being promised a text message to say when it is, and that hasn't been happening either. So I think it's all kind of symptomatic of systems that are heavily under pressure, and the basics are being dropped. if I'm honest, and my concerns really are around what's the effect of that on patient safety. Happy to take any questions.
Right, Zoe, then Philip, then Lee.
Hiya. So, I mean, I've literally, the pharmacy in Knoll is something I hear the most about. And currently there's a confusion about it being closed and then reopening. I have got an email here, if you don't mind me just reading that out. I stopped putting my prescription into this pharmacy around 18 to 24 months ago, as it was rarely open. So we're talking about Lloyd's. The pandemic did make things difficult for them, but nearly always to be closed is just ridiculous. Last time I picked up my medication from them, I was told they hadn't been able to get one of my medications, so they doubled the dose and told me to cut the tablet in half. I asked how I was supposed to do this, and they were dismissive. I then contacted my GP, and they rang the pharmacy to be told that we needed to buy a pill cutter, which they had in stock. When we went there, we were told that they didn't stock them. And then booked with them. The doctors had advised me that wasn't able to get an appointment, and therefore I was made to pay for the flu jab, which I was told would be free. I wouldn't send my worst enemy to them. I was once waiting at the counter for 20 minutes to pay for something while they were behind talking about who was going to the barbers and the hairdressers. It's a total waste of time, even going down there now, as they seem to have the shutters down 90% of the time. From what I see, I've complained and been advised by the doctor to do the same. I've complained to head office and I've heard nothing. Nothing has changed. However, my complaint here is seeing an elderly chap worried as he'd run out of his heart medication and they were closed. They were closed on the Friday, they were closed on the Monday, and they were closed on the Tuesday. This is a massive cause for concern. Not only that, there are times that this place was supposed to be open and it wasn't. There was no notification that it wasn't open. And the majority of the complaints that I get are the attitudes of the staff that are working there, which is obviously understandable if you're stretched or you're low-staffed. But there are people that don't quite know what to do. And in Knoll, there are a lot of residents that can't get to other places. There's a lot of elderly residents around this particular area. The closest one, I believe, now it's closed, is in Tesco, Transit Way. So, it's quite concerning. And is it opening in September as another pharmacy? There's so much confusion around it. No one actually knows what's going on.
Zoe, thank you for that. And what I'm going to do is ask Tony if we park that, because obviously that then comes more into the second part of our thing, where Tony's going to give a bit more of an update about pharmacy. And obviously we've got David and Sue here as well to be able to put views, etc. Because I know quite a few of us have got issues and whatever with scripts and pharmacies and whatever. So thank you for that. And we'll save you from repeating it again in a minute when it comes to that time. But and I think if I just ask anybody else that's doing it, if we can make it more general side of the report, and then we'll take the specifics about pharmacy in a minute. All right. So I just ask you to bear that in mind. Philip.
Thank you, Chair. So in terms of pharmacists, I understand there is a bit of a backlog or shortfall of them. I know we have pharmaceutical students in the Southwest learning. What are we doing to encourage them to practice in the Southwest, specifically Plymouth? Because
I think that's also going to be one of those to park for David and Sue to answer, but that's great. At least they've got it on their list now. So thanks very much indeed for that, that contribution. Lee.
I just want to fully support Tony in his first comments regarding the e-consult. 2 o'clock this morning, it was something that's been on my mind. and I'm glad Health Watch are certainly taking it on board. There are, I liken it to a walk through IKEA, a whole shop, which absolutely achieves nothing, even when you find the exit. I've been forced into the e-consult by the Mayflower Group due to the other means of access being withdrawn, hence e-consult being the only way. If I refused to use it, the call handler would state quite clearly I'd have to fill it in to get access to a GP. Needless to say, I never get to see a GP, even with a life-threatening illness, which takes on board those with long-term problems. With no back door into the software, I think the general perception amongst the publics I've spoken to is that it's more a defence by groups using it to prevent medical negligence claims. And I say this on the basis, one of my constituents actually said the other day, it's very hard for anybody to fully explain their symptoms within the e-consult to come to a rational and well-explained diagnosis, which then puts them clearly at odds with the e-consult system. So it can be deemed that you didn't say this, or you did not say this. If you had said this, we could have made a more accurate prognosis, so therefore that becomes a debate. I feel quite bright, but I found it extremely difficult to provide an accurate explanation to a serious problems my partner was exhibiting, a tummy pain. And anybody reading it would clearly didn't take it seriously. But the actual prognosis was leaking lymphatic nodes causing free-flowing fluid to accumulate in the tummy, hence cancer. So clearly e-consult works against the stakeholder and is only to the benefit of the CCG in practices. Now, another problem with e-consult is the simple fact that it breaches data protection laws. I reviewed some studies that we made 25 years ago, academic studies. Directing patients away from the NHS portal to firstly the web hosts and secondly e-consult health, and I quote, e-consult is not a medical provider. We only provide the online platform to your GP surgery has chosen. A little box requiring patients to set aside the rights would not stand up in court if all other means of access to a service were withdrawn, hence forcing an individual into a particular avenue. When I refused to use e-consult, the receptionist told me she would fill in the e-consult, but negated to tell me she was breaking data protection laws in doing so. And I just asked Tony, when you put together your full synopsis on e-consult, that you'll take that on board, please. And thank you for
Can I
your
point out that
observations.
it's, again, that's one of those things that would be useful in a minute when we're talking with the GP side of things. What I would say is that Mayflower have a consultation that's open at the moment until Sunday, isn't it? So Lee, can you make sure that you put something into that consultation, because that would be very useful. It's online and easily available, and if anybody else wants to fill that in, I will get the link to that sent out, Elliot. I think that would be useful for any of our residents that are Mayflower clients, or whatever you want to call them, all right? But that would be really, really useful to do, so thank you. Ian.
Thank you, Chair. I actually was going to ask a question about pharmacy, but an interesting point raised by Councillor Finn. E-consultants, if you've got several symptoms, it doesn't work. It's almost impossible to use. So I think that's a problem. But the one area I would like to raise with you is to get your opinion, really, because I think during COVID, we all understand the GP services were to a degree shut down. But there doesn't appear to be any easing of the system, and people are finding it really difficult to make appointments, etc. And I would just raise the issue of well-being of people, because sometimes all you need is reassurance. You know, you don't need a consultant doctor, but you do need reassurance. And that's not available in the present system. because of the difficulty of getting an appointment, phoning before 9, etc., etc. And I'm sure different practices have different systems. But by and large, primary care is very difficult for ordinary folks to consult with a doctor. And I think from the public's perspective, they understood that under COVID, but COVID to a degree is lessened and there doesn't appear to be any easing of the system. So I think it's worth considering that, and I would welcome your opinion, because I think the public have a right to be told if we can't ease it because of not enough GPs or not enough staff, then we need to be told that. But most people are left in the dark on this issue. So I'd just raise that if I may, Chair.
Tony, is there any response you want to make to that?
Yes, I think there is. I think with the system at the moment, it's very variable depending on which GP practice you're registered with. So some have systems in place and they have the workforce as well. And things tend to go on in quite good progression in terms of being able to see at least a clinician. You may not be a GP, but at least a clinician to discuss an issue that you have. Others, where there's workforce is more challenged or the systems are different, that becomes more difficult. And I think that's part of the problem we're seeing in Plymouth is this disparity, almost down to PCN level, in my opinion, of PCNs that have kind of got it working and others that are still working towards where they need to be. That's all part and parcel. If you think about it, PCNs is a recent innovation, and they were kind of muted before COVID started, and then they stood up during that period. But I think the system still needs to come to grips. And lest we forget, each GP surgery is its own business as well. So whilst they're being supported by the what is now NHS Devon, and there's frameworks that they work in, they also have business decisions to make as well. And I think one of the problems we have in Plymouth, as we alluded to earlier, is around staff vacancies across the board. So not just GPs, not just dentists, but there's issues with nursing, there's issues in the social care environment, there's issue with pharmacy. And when you start linking all that up, then you start seeing all these problems. So whilst we're concentrating on GPs and pharmacy today, and there are issues within those that need to be rectified, I think there's wider system issues as well that need to be addressed.
Thank you.
Thank you, and that was a very full answer. But I think the problem that concerns me is that I understand that, and you've explained it really well. But the public have no idea about this. We don't seem to be able to get these messages to the public. All they're faced with is a failing service, and it would be remiss of us not to understand that and try and do something towards it. Thank you, Chair.
Tony?
Just to come back on that one, I totally agree with you about patient communication and patient expectation management. The public, if they're informed, will understand. I think where we piecemeal that information to them, it's not readily available to be joined up. But I'll also make the point, again, particularly around GPs and the individual businesses, we've got to get the message consistent across all. And I don't think we're in a position in some areas to be able to do that fully.
Thank you. Vice Chair.
Thank you, Chair. Tony, I've listened to you with great interest, because what you're saying about people not wanting to go down the digital route corresponds very well to some of my Southbury Ward residents who keep on asking me that they don't want to go down digital, they want to see a doctor. So my question, very simply, really, is compared to COVID last year, is post-COVID, are things improving? Even if it's a tiny, minuscule bit, or is it just as bad as it was in the depths of COVID?
I think, in my opinion, from the feedback that we received, there are some areas where things have improved, and I wouldn't say things have gone back to where they were pre-COVID. And to be honest, I don't think we'll ever see that back because of the pressure on the services now, with more people trying to make appointments and that. So I think that's another consideration we need to bear in mind. In other areas, it's very much kind of status quo, and nothing's changed or moved forward to move out of the issues that there was in accessing services during the COVID pandemic, which were there for various reasons, either through government guidance or legislation, or through a need to not only protect staff but also to protect patients.
Tony, you said that some things have improved. Could you tell me what things have improved, please?
So I think some surgeries have got the mix of how you can access right for their patient populations. To give my own example, I'm with a GP surgery on the edge of Plymouth, but it's in one of the Plymouth PCNs. And I can phone up and have a conversation with the receptionist and accept a telephone call back at some stage if it's on a routine matter. I'm a diabetic, so I have a long-term condition to manage. I wouldn't say I'm a frequent flyer, but there are times when the odd question arises or I've got a slight concern with management of my condition. And I feel I can access through that service quite adequately for my needs. But I have the option of doing it online or being able to phone and speak to somebody. I don't necessarily have to see the GP because I'm fortunate with my practice, they have a diabetic nurse. So that kind of way it's set up works for me, but that's probably not the same across the patch at the moment, I would say, in Plymouth.
Thank you, Tony.
Viv.
Thank you, Chair. It seems to me that you're lucky if you have a really good practice that you get on with, and you have a good pharmacist who, works, which it all does for me. It's horrendous what we've been hearing this afternoon, what doesn't work. I do think in areas where it doesn't work, that people are complaining, can't get their prescriptions, whatever. Somebody should be going in, perhaps the doctors from that surgery, and trying to sort it out and having a look at the good practices. I mean, I've moved surgeries now simply because the one I was at, which was very good, and I really didn't want to move, but they're moving down to Colin Campbell Court, and that's too far away for me to travel, so I moved to one nearer home, and they're both excellent. What I cannot understand, really, is when the doctor gives you a prescription, or my doctor sends it straight to the chemist, the pharmacist, and then I get a text to say when it's ready in 2 or 3 days. There used to be a time when the doctor gave you the prescription yourself. You took it to the chemist and he said, oh, just wait 10 minutes, and you got it there and then. I never understand this having to wait nearly a week before they text you and say, it's now ready. That is like going backwards, not forwards. But I have to say, both surgeries that I've been involved with, both pharmacists have been excellent. They're not all bad, but if you've got a bad one, then I just don't know what you would do about that. Ones that close on Fridays and Mondays and
I'm
what have you.
sure that
it's
David and Sue will be able to express the mysteries of how and why this modern technology is done, and I'm sure David will be able to help us as well with that. But I think what I want to do now is say thank you very much to Tony for that introduction. And our next item on the agenda is Joe Turl and David giving us a commissioner's perspective on the position statement and the general practice strategy. And I think this is where Joe will be able to, has been listening in and has heard some of these bits and pieces. And obviously what we're hoping is this new strategy will be answering a lot of those questions and helping patients and practitioners to work through the coming time. And that was in your addendum pack that came out. So, Joe, are you going to lead on this to begin with? Thank you very much for joining us.
Thank you very much, Chair. First of all, I just want to apologise for not being with you in person. I had hoped to come down, but unfortunately I needed to be in 2 locations today. But I do promise I'm going to do everything I can to be there in person next time you invite me. So thank you. First of all, I want to acknowledge, obviously, we've got Daffyd in the room as well, who I know most of you will know. We were both with you last time when we talked about urgent care and certainly the out of hours service as well. So thank you for inviting us back to talk to you about the primary care strategy. I did just want to say thank you to Tony, because I think he really fairly and accurately described some of the challenges in the system at the moment, and I think was really fair about, I think, both the challenges that patients are facing in terms of access and the issues for our patients, but also how difficult this is at the moment if you're sat in primary care delivering those services as well. And I'm sure that's something that David can reflect on as well for us. I think Tony picked out some real key themes, and in terms of a kind of a sort of position statement, if you like, before we go into the strategy, I'd absolutely recognise that those issues with access are absolutely real for some people. I think there are areas which are getting this right, and certainly coming out of the pandemic, we have seen an increase in activity and workload for practices above that before the pandemic as well. Some of that is face to face, but of course not all. As you say, we've moved into more of sort of digital, trying to get a balance between digital and face to face. Now, this won't always be right for everyone. It will be right for some, but not all. But we do need to provide people support. So where we are offering digital solutions as well as face-to-face solutions, we need to make sure we get the support right so that individuals can access services. I think also just wanted to acknowledge as well that as we move into talking about the strategy in a moment, this is very much a draft, and it really is a draft, and I don't expect it to get signed off in its current format. So this really is an opportunity to engage with you on what do you want to see in the strategy moving forward. And I think from what I've heard this morning and from my own reflections about where we currently are with the strategy, I think we need to do some more work in terms of patient access. So particularly people phoning up the surgery, not being able to get through on the phone. I think that's something that probably we need to address a bit better within the strategy. The other thing that I think significantly we need to probably address more so in this strategy, and working with other colleagues, is how general practice works with the rest of the system. So how does general practice work with pharmacy? We'll be talking to Sue and David a little bit later about pharmacy, but there are huge connections that we need to make. Also huge connections with how general practice works with wider community teams and also the voluntary sector as well. And I've heard obviously some of what the councillors have said, so I was particularly interested in what Councillor Tuffin was saying about some patients just need reassurance. They don't necessarily need that professional medical advice, but they need something. And I think that's where working with the voluntary sector, making good use of those social prescribing posts within general practice, we can make quite a difference. And just while we're talking about workforce, I think, absolutely hear what some people are saying about wanting a face-to-face appointment, but there is a balance that we need to strike. We need to make it as easy as possible for people to get the right access, but it has to be the right access with the right individual, and that doesn't always need to be a medic, and it doesn't always need to be face-to-face. And we have to be realistic about the workforce shortages we have, but at the same time we need to make sure that people get the right care. So I've picked up some of. I did just want to pick up some of the comments. I don't want to, I want this to be a really open discussion about the strategy and whether you think it goes far enough. Is it ambitious? Is it ambitious enough? Is it going to deliver what your patients want? But I'm also very conscious that people picked out some specifics there as well. So eConsult was one of those, and I think really good to hear Tony saying actually there are some good signs. So we heard a lot of noise about eConsult a couple of years ago, but it does seem to be improving in terms of the way of how that's accessed, and certainly the re-procurement that we recently undertook as an NHS. I think that's hopefully led to a better solution, but we've got to get it right for everybody, and there will be people that will find that a hard system to use. So we need to make sure that we can support those people to use that and do that. I think there was also I think again it was Councillor Tuffin that mentioned about patient expectations as well, and I think we've got to be really clear. So in this strategy we've got to set out a really clear vision for what general practice is going to look like in the future and how patients can access general practice. And we have made a step change since the pandemic, and we won't go back to what it looked like before, but we've also got to make sure that we provide good quality services. But we need to really clearly set out the expectations for patients and what patients can expect from their practice as well. And I think in terms of particularly some of the specific patient experiences that people have read out, I would absolutely and I think I said this last time, but would absolutely want people to share those if they can get permission from your constituents to share those. That enables us to look into some of those and understand for the cases where it isn't going right, and it goes right for a lot of people, but where it isn't, we can specifically look into some of those and understand why it isn't. So before I open it up, because I think I do want to open it up for people's comments on the strategy, I really want to hear, and I want to hear your challenges to the strategy. What do we need to do to improve the strategy, make it fit for purpose, and give you confidence that we can deliver? But before I do that, I just want to hand over to David and just give David the opportunity from his perspective as well, being a GP on the ground as well as being our commissioning lead for urgent care as well, to give David just an opportunity to give a little bit of a view about what it's like in general practice at the moment.
Thanks, Joe. So yeah, I mean, you've got a copy of a note from my colleague, Dr. Steve Harris, who's the GP clinical lead, very much involved with primary care strategy, who's a local GP as well, who's in practice today, which is why he's passing on his apologies, unable to be here today. I guess as a bit of background in terms of, so I'm very much here as a practicing GP within the Plymouth system. So yes, I have a role within the NHS Devon, but I'm here very much to offer a viewpoint around any questions that you might have. So I've been the GP in Plymouth for 11 years. I've worked in a mix of areas. So I worked in Ernley Settle for 18 months. I worked in Stirling Road, St Budo for 3 years. And I currently work at the Beacon Medical Group in Plimpton, where I've been there for 7 years. So I worked across the city for a fair number of years now, really. I mean, I could talk at length, but I'm sure you've got specific questions that you may well have for me with regards to, and the responses I'll give are my experiences, pros and cons as a practicing local GP in the system. So I think, let's be absolutely clear, things are incredibly challenging, your demand and capacity. And does that impact patient experience? Of course, yes, it does. Does it impact related to access? Does it impact outcomes? Of course. So I think so I absolutely applaud a strategy document that very much looks at our workforce, looks at demand, how we manage demand within the workforce that we have, but how do we retain that workforce? How do we grow that workforce? How do we create Plymouth General Practice as a vibrant place to want to work and that offers work-life balance, professional fulfillment, all of those things which are fundamentally important in any industry, in any area within workforce. So I could talk at length, but I think it'd probably be more helpful if you've got some specific questions, and I'll answer those as best as I can, as I'm sure Joe will as well.
Thanks, David. And just to point out to people that a supplementary pack came out on, I believe it was Thursday or Friday, Elliot, and that's got the primary care strategy draft report in it, hasn't it?
Yes, it has, Chair. I've got more on the way as well.
Thank you. Okay, team, right. Joe and David presumably will, well, I know they will take questions, not presumably, they will take questions if we've got any thoughts on it. So I've got Lee first.
Yeah, I think the general perception is in Plymouth that these services, no matter what access to services, exists in name only and for the benefit of the employees, not of the patients. I do take on concerns, reference what Joe said, imposition, what they can expect. Things won't go back. We will persist. Strategy is not patient focused. It's almost that the actual strategy is preordained. Patients don't want platitudes, they want a timeline to improvement. And what worries me is that when we discuss things within this group, at the last meeting, I was told by one of the senior executives at Derbyshire Hospital, possibly we should meet and have a cup of coffee and discuss the concerns. I shot off an email, needless to say, there's been no feedback whatsoever, so I think that sets this committee aside and affects every member of this committee. As for primary care, prior to the installation of the CCG in Plymouth, procurement of primary care services was extremely good, providing for a service that retained the public trust and respect. Clearly, that is not the case today. The question is what went wrong and how you're going to put it right. I guess a clear example of that is regarding the contract given to the Mayflower Group and Devon Doctors by the Clinical Commissioning Group, both subsequently placed in special measures. The CCG must have known the two aforementioned contracts were failing 3 years before they were actually found wanting. The patients knew it, and the stakeholder reviews, which were clear for everybody to see in this room, were there to be perused. Yet the CCG, the procurer of the contracts, did nothing. Instead of taking robust action, they allowed these failing organisations to put at risk the health of hundreds of patients in legal terms and therefore become severally liable. When we talk about GPs, your statement that GPs are leaving because of the pressures created by the workload is misleading. The part of the statement that makes any sense is regarding the load you created, allowing, let's say, closing Collins Park without carrying out an impact assessment to whether Man and Marie surgery could actually cope with the extra 8,500 patients. Same applied to Chard Road, Mayflower Group. Dr. William Reeder and Jan Longworth were excellent GPs that I had to build up a fantastic relationship with over the years. They were driven out the service by the actions of the Clinical Commissioning Group and non-patient-centred practice management responding to a diktat. Dr. Reeder told me categorically there is a new breed of GP that does not want to see patients. Is that true or false? This is a consensus that 3 retired ex-GP friends of mine agree with. Surely they cannot be wrong or be wrong. So people don't want a talking shop. What people want to see is a start, a middle and a finish to when we're going to get some sense of normality with regard to services to take this city forward. Thank you, Chair.
Thank you. Anybody else? David?
Just a question, Chair. Just looking through on 2.15 digital. Digital front door will continue to be the route into care, etc. We ensure this does not disadvantage those who do not have access to modern technology by agreeing standards with general practice for support to people who need it. My question is how? In my own particular ward, we've got something like 60% of our residents are over the age of 60, roughly. The vast majority of those, and we're talking therefore thousands of people, do not have and do not want to have anything to do with computers or whatever. They just don't understand them. So when you say by agreeing standards with general practice, what standards, how are they going to be agreed and how are they going to be implemented? Thank you.
David, can I just ask you what page that's on so that the rest of us can catch up?
On page 14 on 215 digital.
Thank you.
On the new one we just got.
Yeah, lovely. That's
pack.
great. I think you're being disingenuous to silver surfers because there's an awful lot of people that do embrace digital, etc. And I think there'd probably be quite a few 80 and 90-year-olds that would take offence at that. But I think you're right. I think it's in principle it's making, we have to make sure that a system is accessible for everybody, regardless of whether they can use digital or not. And that is one of my beefs where the council is concerned, because the council is going down the completely digital route. And I maintain there are a lot of people that can't do that. And I know that's, so I think it's something that we're aware of in the council, and I think we have to make sure that they're aware. I'm sure Joe will take that on board. And I think it's interesting from Tony's perception and his report about general practice, where he is saying there is a fair number of people who want that option to either be able to do digitally or by phone or whatever. And I think this is something that Joe and David hopefully are listening to and will take forward. And I think that's, are we happy to make a recommendation that any strategy must account for doing a digital online or whatever app concern, and also being able to get through by phone? There needs to be a variety of ways to make sure that you can access your GP surgery and make requests, really. So I think let's work out how we phrase that. But to me, what you're saying there, it jumps out that we have to have something like that.
I wasn't trying to be disingenuous at all whatsoever.
I'm sure you won't, David.
I can
I'm
only
sure
go on
you
what I'm
won't.
told.
Yeah.
I just found that slightly flowery.
Yeah.
But yes, definitely we need to
We
include
need a
non-digital
recommendation
means and
about
everything.
that.
Thank you.
Definitely, we'll work on that.
Sorry, Chair.
Mark?
I think that is absolutely crucial, that we need a multifaceted approach to, you know, to GP surgeries, to make it all inclusive, because, you know, if it's just digital, then thousands of people are just going to miss out, and you know, that can happen.
And certainly I've been in a surgery where somebody was saying they could not get online, and then they were told to do X or Y to get through on their digitally on their phone, and he was saying, I haven't got that type of phone. It's just a basic bog standard phone from quite a few years ago that does not have that. So yes, and I think we have to realise that there are people that can't do that. George, you had your hand up.
Yes, thank you, Chair. On Councillor Salmon's point, I certainly agree that access, non-digital access, is important. Can we stress that that should avoid the 4-hour wait on the phone as the only way of getting through? There must be ways to avoid that, and even if a system for calling people back is used, but the idea that the only way you can get through is to wait until 12 o'clock, you phone in at 8 o'clock and you get answered at 12 o'clock, is quite appalling. Not many people would wait that long. I certainly wouldn't, but I'm told that it has happened, and it shouldn't have to happen. So can we add that to any recommendation about telephone access, please?
I don't see why not. And David, presumably your surgery checks on how long people are hanging on to a phone, and I don't know whether you can give us any clue as to timelines.
So we do, and I think one of the things that's been highlighted is, or reflected, is some of the variation or the variation in how things happen across the city. I mean, I think I just want to come back on a few, and again, I'm here very much offering a local GP voice. So as I say, my colleague Dr. Steve Harris is working very closely with Joe around the GP primary care strategy. But clearly as a local GP and someone that works for NHS Devon around sustainable urgent emergency care, as we touched upon last time we were here, sustainable, responsive, same-day general practice is absolutely critical in that space. So just to give you some figures, just to bring this to light, and I can absolutely assure you, I didn't go to medical school and I didn't become a doctor to sit on the end of a phone. And I can tell you that doing that does not give me professional fulfillment. It is an approach trying to best manage demand with the capacity that we've got. So within my own surgery, we've lost the equivalent of 3 whole-time equivalent GPs in the past 2 years. And we've tried to recruit to fill those 3 whole-time equivalent GP vacancies and been unable to do so. And so that work, clearly those patients have to be managed by those people that are left available. So that's part of the context. Within my own practice, just to give you, just a feel, so this is 40,000 patients, which goes outside the city boundaries within Plymouth, but at least 30,000 patients within the city boundaries. On typical Monday, we'll have 1,000 calls in a given day, 600 calls Tuesday to Friday. So if our practice is a typical practice, when you scale that up for the area that surrounds Derriford or for the Plymouth city boundaries, you're talking at 25,000 calls in any given week. Our calls have remained static over the past 2 years. The context, there was a national context under a previous health secretary, which was very much about pushing the digital agenda. And there was feedback. I'm sure Tony's touched upon feedback from patients. There was a lot of feedback from, particularly, and I'm generalising hugely here, people of working age saying being offered an appointment on a Tuesday at 3 o'clock when I've got to pick my children up is wholly not ideal. I can't. And for essentially a problem such as eczema or a rash, that I know what it is, but I do need some cream that I cannot buy over the counter from my local pharmacy. So is e-consultation perfect? No, it isn't. It is merely, there are places where it can be useful. It can be useful for certain patient groups, but not for everybody. And so I absolutely applaud there needs to be a multifaceted approach. Access is not a single entity. The approaches that we are taking and the practices are taking are those where we're trying to provide responsive services to as many people as we possibly can within what are significant constraints in terms of workforce and numbers. I think understanding some of the variation across the city is really important. I absolutely agree with that. Our e-consultation numbers over the past 2 years, and again, I'm making this point just to illustrate what we are trying to manage, the totality, because these stories are really powerful. These patient experience stories are really, very, very powerful. E-consultation, our numbers are around 1,200 to 1,500 a week. You scale that up across the city, that's 10,000 e-consults per week. And that's risen by 25% over the past 2 years. So our capacity within as a practice has dropped by 3 whole-time equivalent GPs. And the GP workforce is broader than just GPs. I absolutely accept. And there's been some fantastic examples of creative innovation with workforce, with paramedics, pharmacists, nursing colleagues, and what have you around that. But the facts are, the numbers, the demands are going up, and our workforce is really challenged. So how do we provide a responsive service to all of those people that very legitimately want some advice, want some reassurance? Time is the biggest asset I can provide using my training to manage complex issues, we are human beings at the end of the day. And these issues are not, as I think a colleague raised, it's not a single, very simple, straightforward issue. Often it's lots of different things. These are imperfect solutions to what is a really huge challenge at a national level, but within the city boundaries, clearly within the city of Plymouth, we are at one end of that scale on the backdrop of what is a national, huge workforce issue. Now, so for me, I think it is about portraying within a strategy document something that offers hope, optimism, incremental improvement, working with colleagues such as Dave with community pharmacy. I see huge opportunity, and I won't steal Dave's thunder to start talking a little bit about that, because we are overwhelmed with volume. And I can just absolutely assure you, when I think about my career, if I'm sitting there in 5 years' time purely sitting on the phone, and we are seeing people, we absolutely are seeing people, but the telephone, I can talk a bit more about e-consultation in a minute, is a way that allows us to try as quickly as possible to respond to as many people as we possibly can and really pick out those people who really will benefit from, and when I say benefit from coming in, that isn't just purely what I think as the doctor on the other end of the phone. If the patient I'm talking to, for whatever reason, really feels that actually that's the only way I can resolve this particular issue, I would bring them in. Now, I appreciate there are some harrowing stories around people that have had harrowing experiences with patient experiences, which we've heard today. So am I saying that's happening all the time? No. What I'm saying is that those demand figures are just to give you a feel for what we are up against within our workforce. So any strategy has to be, how do we retain, grow our workforce? How are we clever around actually giving people as responsive services as we possibly can? People, in my experience, have had excellent experiences of working with our community pharmacy colleagues around things such as simple urinary tract infections, some simple skin rashes. There are a number of areas that there's huge opportunity. So the future, there are solutions out there, but what I'm saying is that things are really, really tough. And on the whole, I can't speak for everyone, on the whole, my colleagues are working flat out to try and do as best as we, as we possibly can.
Thank you. And I think this is where this draft strategy is looked at, and we help to contribute towards some of that unpicking of it, and perhaps being able to offer some suggestions that will make life a lot easier. Because as you say, we value the workforce, and I know from years back, Plymouth being down in the southwest, often you didn't get people coming for interviews even because they'd stopped at Bristol or Taunton or even Exeter before they got to us, So I think this is exacerbated now, I think, because of the pool is less than what it used to be.
Yeah.
All right, I've got Ian and Natalie in. Oh, I'm sorry, I'll take that back. George is first, then Ian, then Natalie.
Thanks, Chair. Well, Dr. Jones is just giving us a very powerful indication of one of the problems anyway, and that is that we don't have enough GPs. And that came out clearly from Dr. Harris's comments as well. It takes about, 7 years to train a GP?
Yeah, so it's 5 or 6 years at medical school, 2 foundation years after that, and then 3 years. So 5 years post finishing medical school. Yeah.
Thank you. And I was looking at some statistics this morning. I think it costs about £200,000, so it's not cheap. But what I'm getting at is last year. This current year, there were suitable applicants for medical school places, and there were medical school places available, but there was a cap. And so some people, some potential GPs are not undergoing training, and they won't be available to service in 5 or 7 years' time. Can we put a recommendation to the Cabinet or Council that the government is asked to remove that cap? It won't do anything for 5 or 7 years, but if we don't start now, we will never start to improve the position. I noticed that the Medical Schools Council was advocating an increase of an extra 5,000 places from 9,500 to 14,500. They did point out that would cost an extra $1 billion, so the government might look a bit questioningly at it. But we do need more GP training places, and I think we should ask for it. If we could try to start the ball rolling, perhaps.
I think that's reasonable. Obviously, whilst we can't aim at GPs in particular, it's raising the number of entrants into medical school training, and certainly we've asked for that for dentistry, so I don't see there's any reason that we can't ask for an increase. So I think if we can agree in principle to that being stated, what I will need to do is to find out how the correct way of making that request is. Basically, as a chair of health scrutiny, I can send that directly to the Secretary of State for Health as a proposal. So if that's okay with everybody, that's what we'll aim for. But I will take guidance from Elliot and the team as to where we do it. But we will certainly, I would say, let's aim for the Secretary of State. There's a new Secretary of State maybe she'll be more sympathetic than a previous one. So we can but ask and do that. But yeah, Lee, do you want to come in on that?
Yeah, I'd just like to say, with regard to what David said, I fully understand that in some respects, but at the same time, you've got to equalise that out with the way the current system currently operates and is driving out older GPs. I think on the side of recruiting, we also need to think seriously about actually retention of GPs. What are you doing to retain GPs? What are you doing to make the pathway clear for them? Because it's no good waiting for the next 7 years to find another GP. As we know with mast cell disease, systemic mast cells, Dr. Reader was one of the few people that actually understood it. People will specialise in different areas. Therefore, that catch-all recruit a GP is going to cure the problem is not going to cure the problem, I don't believe. So we must take into consideration whatever strategy is imparted, considered and put into place, actually takes into place the retention of GPs and bringing back these GPs that have actually been driven out the service with years of experience. You know, some of them have got 20, 30 years experience. What are you doing to bring them back in? And I think that needs to be brought into serious consideration.
Lee, I'm going to stop you there because what I was thinking, you're just going to wanted to come back on that comment about GP training, and there's others before you to come in on that. So I'm sorry, I'm going to cut you off there. David, I've got you on my list. Okay, but just taking that as a recommendation that we write to the appropriate person and recommend an increase in medical school places. Okay, right. So going back to my list, and can I just say, we're trying to comment about a strategy that Joe is putting forward in the understanding that this all comes under what government is giving in direction to the Devon NHS and whatever, and how this is all going to be. So this is how we want to make our views considered on what we think the strategy should be containing, and how we support the provision of GP practices in Plymouth, etc. So just bear that in mind. All right, please. Ian, you're going to be constructive, aren't you?
I am. Well, perhaps. A question on strategy. Who are they? Who are the consultees for this strategy? I'd be very interested, because I know we've got Tony and Health Watch, but I was wondering about patients groups, if we could hear a little bit about that. And if I may, Chair, I think a really good point's been made this afternoon, and perhaps we as committee members need more information regarding GP services and the pressures. And because it's easy for us to criticise when we haven't got that information. So it might be a recommendation that we get supplied with that information. So we're in a position to comment from a position of knowledge, rather than most of us just see a small picture of things. I think that's a reasonable recommendation. Perhaps we'll talk at the end of the meeting. Thank you, Chair. Thank you. Joe, can you let us advise us as to who your consultees are? And then I suppose the challenge goes to David, is there any way that we can pull some sort of briefing together, maybe at a GP surgery, to show exactly what you all get up to all day, rather than drinking coffee all day? All right, maybe that might be, you know, sort of a few of us go and experience what it's like behind the scenes.
Absolutely. I mean, so further to the last meeting, I had a conversation with Councillor Mahoney, who, as I'm sure many of you know, has a GP background himself. So Councillor Mahoney came and joined me at Beacon on one day, just to give him a flavour, really, of the type of, bring to life some of the issues that we've talked about, looked at e-consultations and what have you. But I think words are one thing, but seeing things with your own eyes are, you know, is fundamentally important, isn't it? So I absolutely agree with that. Yeah.
Thank you on that. And Joe, do you want to just come in about who the consultees are, please?
Yes, thank you, Chair. And I don't know whether you'll allow me the opportunity just to comment on, because I think people have raised some important issues. So if you're happy to, Chair, I will answer Councillor Tufnell's question first. And I'll just cover a couple of the other things that have been raised. So within the strategy document that's been shared with you, and again I'll reiterate, this is a draft, so this is part of the engagement, and speaking to you today really is an opportunity, I hope, to speak with you and understand from your constituents' perspectives what the issues are, and whether this strategy goes far enough in terms of addressing those, and whether you've got the confidence in that. So the strategy itself, but also in the paper at the beginning that just gives an overview of the strategy. It does go into some detail there about the engagement that's been done, and I think it's very extensive, and that's included patient groups as well as it has Health Watch, and also of course practices themselves, as well as other partners in the system as well. I think just in terms of some of the issues that have been raised, I think there's been some really important points so far that have been raised that I want to take away. So I said at the beginning, I wasn't sure we've gone far enough in terms of addressing the issue around access in terms of booking appointments, and I think that's come up again. So certainly I heard from one of the councillors, and I'm sorry I couldn't quite see your name tag, I'm afraid, on the table, but that wait in terms of phoning up a practice, and you should always be able to phone your practice. So no matter whether practices are using eConsult, other online consultations, you should always be able to phone your practice as well. I think at the moment, though, those waits are longer than any of us would want them to be in some of our practices, and I think that's something we need to address in that strategy. So absolutely, we'll take that away. And I think again, Councillor Aspinall as well talked about that multi-access, and I think that's really important. So there need to be multiple ways in which people can access the right help and advice they need. The advice and help they get might be delivered in different ways, but that has to be based on clinical need as well. I think one of the other issues that was mentioned as well was around the timeline for improvement, and I think that's a really important question. So when do we expect this to deliver? And I think we need to be able to answer that. I'm not going to say that that's going to be easy, because some of these are going to be longer term solutions. If they were quick, we would have solved them already. But I think expecting some sort of timeline, expecting us to work with yourselves on what that looks like, I think that needs to be an important part of the strategy. One of the other areas that was mentioned was around digital, and particularly older people and some practices, patient demographics having difficulty with as I said, accessing some of that online digital information or booking appointments. And I think whilst absolutely agree there need to be, as I've said, multiple access points, so I don't think it can be online only. Actually, there are a lot of people who want to access services digitally. So we've done a recent piece of work, and in a recent survey that's been undertaken, 92% of adults in the country have access and do use online digital ways of accessing services. And 54% of over 75s are very active users of online. So I think, Chair, as you mentioned, I think online is part of the solution. It won't be the solution for everyone, but actually I think we'd be doing misjustice to people if we didn't recognise actually that people do want to access services in that way as well. And then lastly, the other point I wanted to pick up was about the commissioning of primary care. And there have been some long-standing issues in Plymouth, whereas we know there have been practice handbacks since, we're going back now probably about 6 or 7 years, which is prior to the CCG taking over the commissioning of general practice. In fact, most of the practice handbacks were prior to our time, and certainly the procurement of the what was the old Mayflower group of services was prior to the CCG taking on the commissioning of that. But that isn't to say, though, that this isn't really difficult. And as a commissioner, I think we're facing some significant challenges, as we've heard from David, in terms of workforce, in terms of demand, in terms of overall capacity. I think this is a real problem, and that's why it's really important that we get the strategy right. And I think one of the potential solutions to that, which I think we need to build on, is how general practice works as part of a much wider integrated system with community services, with acute providers, with voluntary sector, and with the wider community as well. So I hope, Chair, that's just picked up some of the key issues that have been raised so far.
Thank you very much indeed. Yeah, I'm moving now to Natalie.
Lovely, thank you, Chair. Yes, just briefly, I just wanted to touch back on the workforce issue where we said obviously that it could take potentially 7 years to train up to be a GP or a practicing professional, but bearing in mind there's 37% of our workforce at the moment that are over 50, and I know that there are major issues. We really need to be very much promoting, because we've not only got those that are just leaving because they want to leave, we've got people that will be retiring, and therefore we need to really, really ramp it up, because the percentages we've got of our younger workforce are just not going to cut the mustard. So it's more than our retention, we're not getting people in. We're going to lose people because they're going to who are committed, who are going to retire. So that was just one brief point. The other point was back to the e-consult. I'm afraid. Obviously, we say about digital, and we say that yes, 92% of the country are digitally enabled, shall we say, or accessing digital. But you might be able to access it, but if e-consult doesn't allow you to access it, and if you're a working person or you've got other commitments, and the only time you can access e-consult is during working hours, you're back to square one, because you can't actually access. And you can't phone, because you can't be on the phone for hours on end if you're meant to be working. So, it's making sure that the e-consult is accessible to everybody as well. Thank you.
I did overhear a conversation this morning between a receptionist and somebody that came in and was asking about e-consult, and they were actually saying that it was open from 6 in the morning till midday, which was quite interesting, because you wouldn't get me waking up at 6 o'clock to do it, but it's interesting, and I think David will probably echo that there are all sorts of different times that different surgeries do, which again is one of those tools in the toolbox. But if you're somebody, let's say, has done a night shift and gone to bed at 5 a.m. and doesn't get up till 3 p.m, then it's a different matter, isn't it? So I think it's all these things that are all contributing. So it's good. I mean, Joe's listening to this, and that's what this session is all about, is Joe and David taking on board.
Thank you. I mean, I'm very lucky. I don't need to see, and I was asked this question by my stepfather last night, what's your GP surgery like? I'm very lucky, touch wood at the moment. I don't have much experience because I don't need to use, but my one, not open at the weekend, the e-consult not open at the weekend and not open out of working hours. What good is that to me if I did need to contact them?
Exactly, and modern day life is very different to how it used to be. I've got David, and then I'm just bearing in mind that the time is moving on, and that we've given this a good discussion as far as I can see. So unless you've got anything additional to add into the mix, then I need to be coming to an end soon. So I've got David, I've got George, I've got Zoe and Lee. And then I'm moving on, folks. Okay. Sorry, and Mark. Sorry, right, we'll stick that. And then I'm coming to an end, because some of you have had more than one bite of the cherry. All right, David.
Thank you, Chair. To me, this whole thing comes down to a situation of like patient expectations versus the availability of time, which is obviously going to differ on every single pharmacy. Take Councillor Wheeler's point as well about the time. When you can eventually get through, you talk to a receptionist for triage, etc., etc. The doctor will call you back. I've had a time where I said, well, when? This morning, this afternoon? Not sure. So now that's your whole day sort of taken up. And it's exacerbated by how good it is, because my previous surgery was absolute rubbish. I've now changed to one which is brilliant, and so's everybody else. That's the problem. So the time goes up and so on. But just as a total aside, I'd like to thank Dr. Jones. I listened very attentively, but don't despair, because I mean I'm in awe of doctors. I can't even pronounce most of the medicines I'm given. So thank you very much. Thank you, Chair.
David, if you could sort of take that into consideration as to, is there a time frame between somebody phoning, let's say on a Monday morning, and getting through, and does just sort of, I'll come back to you because there's bound to be some of these others that will come for an answer. Is there a time frame that the average surgery works to for a response? That would be quite useful to know. George.
I wanted to pick up the same point, please, Chair, because I think the first time I tried to use eConsult, it was about 6 o'clock in the evening, and I was a bit amazed to see you can only use it between, I think, 9 to 5 or whatever it is. eConsult isn't interactive. Why are there any restrictions at all on its time of use? I can understand that someone is only going to look at it between 9 and 5 or whenever, but you could surely put in you can make your request out any time of the day, and that would be far more convenient for people who work, because it can take a little while to fill in, and you can have to go back because it can tell you, oh, we can't solve this problem, you'll have to try somewhere else, in which case you have to alter what you've done to make sure that you can get something submitted. So it can take a bit of time, and if you can do that in an evening when you've got some spare time, it would be a lot more convenient for a lot of people. And I just don't understand what the restriction is.
Thank you, George. And I think that's one of the things that eConsult was probably one of the first things, and sort of, has there been developments to alter it and to make it a little bit easier to do? But certainly I think my understanding is that each practice seems to have its own times as to when it's open. So again, David, that might be something just to sort of bear in mind. We'll get an answer in a moment, all right? And again, Joe is listening well to that as well. So, Zoe, you're next.
I'm happy to have this via email and save time, but I do have a constituent who is constantly asking me questions. And in the strategy report, it says increased signposting. How is that? Who decides the signposting, and at what point is the urgency, especially in mental health? How does that work? Because I do have a resident who was signposted to a leaflet and then had a breakdown days later. So how is that decided? And the other thing, sorry, is what does it look like? What does the deprivation bit look like? What is deprivation? What areas are considered deprived? What do you have to meet to be classed as in a deprived area? Those are just the two questions I'd have.
Joe, if you can sort of consider those in a minute, and that's fine. And I mean, I think deprivation is probably what it's, I'm not saying a universal definition, but it's something that you may well be getting from the Public Health Council as much as anything else, isn't it? So perhaps if you can come up with an answer to that, I'd really be grateful in a moment. Right, I have Lee and then Mark.
Yeah, just to add regard to eConsult, for example, it's an impossibility for those with numerous medications to sit down there and fill an eConsult in. Say, for example, myself with 32 medications, well, I don't know exactly what doses I'm on. If I was to sit there and try and do an eConsult, it's absolutely impossible to do so. So something needs to be looked at in regard to eConsult and people's ability to be able to explain their medications in line with a symptomology. But I think another thing that this has been sort of digitally driven this afternoon. It's all digital this, digital that. What we've negated, nobody's actually mentioned, what about walk-in centres? What about GPs actually providing a centre to which people can actually access, say, on a weekday from 9 to 6, or people that are working? I know Mayflower Group tried it a few years ago with regard to Mount Gold, which was a perfect facility, and it worked really well. People could see a GP up to 8 o'clock in the evening. So it doesn't have to be all digitally driven. We can do face-to-face and we can make it accessible. All we need is the will to do so. Chair.
Mark?
Thank you, Chair. I shall keep this brief. Most of the things I would like to talk about is people's mentioned beforehand. But David, if I was a newly qualified doctor, bearing in mind that GPs work long hours and it's very stressful, they're relatively on low pay and with low morale, how would you convince me to become a GP?
I hadn't envisaged that question, but I'm happy to. So, I mean, I can only speak from a personal perspective. What attracted me to general practice? I applied to GP training in 2007, and I'm someone that trained in the southeast. So, and I was attracted to the southwest as a place to live. Really, that was. But anyway, the question: what attracted me to general practice? So for me, it is a fantastic, rewarding career where you, again, this is going to sound incredibly, but holistic care, biopsychosocial care. So you get to know your patients. Continuity is crucial. There's a lot of evidence to show continuity translates into improved patient outcomes. So if I think of some of those cases I really add value to, which are those people that I know well, I know that they're on 32 medications. I know what their medications are. I know their personality. I say know their personalities. I'm familiar with those people, and it's really fantastic being able to get to know them and follow them up over a period of time. So variety was a big driver to me. So I would do a hospital placement. So I have a specialist interest, although I don't do it too much, in clinical allergy, and to people that have. So people that have food allergies, drug allergies, etc. And I would get to the point that the clinic would be quite repetitive. That's not meant disrespectfully to any colleagues that find a specialty that they absolutely adore and love. But for me, I loved the fact that you'd see a pregnant lady followed by a brain issue, followed by a stomach issue, followed by a breathing issue. I enjoyed that variety. And that for me was intellectually stimulating, and I enjoyed that. So there are three things with any job for me. There is work-life balance, and that is a nebulous, generalized thing. It varies from person to person. There's professional fulfillment, and yes, there is a money element for anybody in any work. So I think the thing that the NHS GP has always been about has been that professional fulfillment arm, which does require time. We've got Councillor Mahoney here, retired GP. So you do require time to get to know your patients. You require time in a workforce to deliver continuity, and there are huge benefits from being able to do that. So that, for me, is what general practice is about. Variety. It's about holistic care for your patients, getting to know your patients, and those reasons I went into general practice are no different now as they were before, except the time that you have, even over my 11 years in general practice, is less. So any strategy has to look at how do we, and I think it's a very good point that was raised regarding this isn't just about recruitment, it is about retention. So again, I go back to the demand statistics, the capacity. We've lost 3 whole-time equivalent GPs for a range of reasons. We do need to release some capacity that allows those really professionally fulfilling elements of the job to return. And I accept the point regarding walking. There are groups of people that are patients of mine that I will always see face to face. And again, the telephony, the digital first, does it work for everyone? No, it works for a number of people, but does it work for everyone? No, it is a tool amongst a suite of tools. And a really good access model has a bit of everything in it.
Thank you for that. And Joe, you're going to be garnering all these bits of information from presumably various scrutiny committees and other relevant bodies within Devon. You're obviously working to a national review here, the fuller stocktake review that you're mentioning, and presumably then there is what basically is coming out of government and the Department of Health, etc., and what their plans are, etc. So I think what I'm wanting to know from you is, when are you going to be finalising this overview and coming up with it? Won't have draft over it any longer, and will you be coming back to us before you reach that stage where you're taking the draft bit off this report? And how can we help further? I mean, yes, case indications from our constituents, whether that they're positive or negative. You know, if we make sure that my colleagues on the scrutiny committee have an email for you to have those comments from residents, then that would be useful. But I'm just thinking, how and when is this all going to be pulled together?
Absolutely, thank you, Chair. As I started at the beginning, we've been engaging for some time now on this strategy, but I think there is still, and hence why we're here now, and I'll be going to the other scrutinies as well. I think there is still more to do. I think we haven't addressed. It's quite interesting because it's come up certainly from the last few comments. There are some things around access which I don't think we have addressed as much as we need to. Now our hands are slightly tied because there's a standard national contract with general practice, but things like standards for e-consults, so when you can access them, what time of day of week, etc., standards around answering the phone, standards around getting callbacks, etc., none of that's explicit within the contract. But what I would like to do within this strategy locally is set some standards that we would want to work towards and work with general practice around that, understanding though that some of that is going to be difficult, and we know there are huge demand workforce capacity challenges. But the answer to that, and what we've got to do within the strategy, is describe what the answer to that might be. And I think very, very strongly what's come out of very recent engagement is we need to go further around how we integrate services locally. And I've mentioned some of the partners already with which we need to do that. So I think that's the next piece of work we need to do. I'm also very conscious, as you say, Chair, we've got a new Prime Minister, we've got a new Health Secretary. So I think we do need to just take a little bit of time just to understand what that means in the context of the strategy. But I would absolutely like to see that we are coming to a conclusion on this piece of work before Christmas. Certainly within the autumn period, I'd like to think we're getting to a final stage that we would want to come back and say, actually, this is the final strategy that we want to sign off. Very happy at that point to take comments and questions about whether you think we've adequately reflected, and I suppose most importantly, what you want to see from us post the sign off of the strategy, because at some point we will need to draw a line in the sand, but absolutely expect you to want to call us back in terms of what does implementation look like and what are the timelines associated with implementing and seeing change on the back of the strategy. So I hope that's answered your question, Chair.
Thank you very much. I think, yes, we'll need to work that into a timeline. I know we've got a November scrutiny meeting, but whether it actually is late enough in the year for you to have that finalised, then I think if we can work with you through Elliot and Anna, we will come back to you on a date on that. And if it needs to be an additional meetings that we can help you with signing off that, then that will be worthwhile. But I think it is essential that we keep track of what's happening, and it'll be interesting to hear what you've picked up from the other scrutiny committee in Devon, and it will only be Devon County, won't it? And Torbay, presumably, they feed into the Devon one, don't they? So North Devon, I don't know how they feed in, but it's Exeter and North Devon together, isn't it, there as well? So I think it would be useful to hear what other scrutiny input is. Then I can't see that it being very much different to what we've put in. So it'll be useful. So thanks on that, Joe. And we will be in touch. And thank you both to you and David for your contribution today. And I thank all my colleagues around here, because it's something close to all of us, because we're all using these services, you know, and that's what's important, isn't it? So thank you very much indeed. And we'll get the recommendations that we've put together here, we'll get them to you so that you can pick up on that. Okay.
Thank you, Chair. Just want to say thank you very much for all the feedback from everybody. Thank you.
Right, folks, thanks very much indeed. We're now moving on to the report that we've actually got here in front of us from the patient experience on pharmacy services. So I'll go back to Tony now to say a few words about that, please.
Yes, certainly. I think we've covered some of the if you like, the findings of the report. The report came about, just to put it in context, because we were approached by Public Health in Plymouth during the drafting of the pharmacy needs assessment for 2022 to 2025. So we historically went back over the last financial year and looked at how much feedback we had around pharmacy services. And one thing that surprised me when we did that review was, you know, the amount of comments we'd had about pharmacies in Plymouth compared to the rest of Devon and Torbay. So the report really focuses on the issues being raised by Plymouth residents about pharmacy access. And pretty much Councillor Riley's email that she read out covers all those themes around communication, around opening times and staff attitudes and that. So I think the report is relatively easy to read in what it says. We've put some comments in there to back up the themes and that around what residents in Plymouth have said. And I guess my one concern is with the move towards community pharmacy, taking more of a role in taking some of the pressure away from GP surgeries and potentially, you know, stopping patients turning up at emergency departments as well, where we see staffing capacities, what's the effect of that on the community pharmacy itself and how that then works moving forward. So I think we're back to, in a way, a little bit of a workforce issue. And again, noting that pretty much all the pharmacies are private businesses in the way that they work, and they're commissioned to provide NHS services against the pharmacy needs assessment, is my understanding.
Thank you, Tony, about that. And this report, who do you share it with? I know it'll obviously go on your website, but who else gets shared it?
So when the report was pulled together, we shared with all the public health teams in Devon. I certainly shared it with David and the team there, and it came in to the local care partnership boards across Devon as well. And the final area it went into at the time, it was the CCG, now NHS Devon.
Thank you for that. Anybody wish to raise anything with Tony about his report? Not about anything else, but about the report from Health Watch. Ian?
If I may, there's no mention in there of unavailable medications. I know it's become a problem recently. On a personal level, I've had difficulty, and I'm surprised that that wasn't raised with you as an issue, because we don't seem to have a true picture of what's happening with availability of medication. Certainly, we all see it through our little spotlight, And I've got concerns that maybe it's a bigger issue than any of us understand. So I'd welcome either you or David's view on that, please.
I think I would agree with you on it, but it wasn't really evident in the reviews that we had. There was issue, so if you take it as a supply issue and put that to one side, what people were saying was their actual prescription wasn't ready rather than the medication not being available. I'm aware through sort of bulletins that I get to see that there are supply issues, and there are regular supply issues for certain medications, and the information I get is factored into a GP bulletin that I receive. So from a Health Watch intelligence point of view, we're aware about that, but it's not explicit in the patient comments that we've received.
And perhaps we can ask David and Sue to take that up as well. The list must be getting quite long there of what they've got. Right, Lee, and then Sue, and then Patrick.
Yeah, just a quick one. I think it's a very comprehensive report, and thank you so much for your time putting into that. I have to say I'm lucky the boot surgery in Crownhill with Rob is absolutely brilliant, and they do put their patients first. But one thing that came up, I'm just talking from experience, when we talk about how far pharmacists actually take on the work of GPs, etc., I believe that there is an opening there. Say, for example, in Turkey a couple of years ago, the missus got bitten by a mosquito. She had an infection, it blistered up. She was able to go to the local pharmacy without going to a GP and bothering the GP at the time. Bearing in mind she had cancer, so it was imperative that we actually dealt with that and just finished chemotherapy. The pharmacy over there was able to actually offer antibiotics and an antibiotic cream straight away, which cured the problem. So therefore, when we talk about pathways, is there any discussion within the papers, or likely to be future discussions with regard to pharmacies actually taking on, say, a minimal role with regard to that, to relieve pressures on GPs and provide an instant access for the publics we purport to serve?
Again, I think that goes to you rather than Health Watch, because it's obviously not been brought up in your report. So David's got that on his list. Okay, excellent. Sue.
Thank you, Chair. My question, Tony, is to you. On page 17 of your report, I'm interested in the rationale behind the sample of different pharmacies. It may be that these are the only pharmacies, but I'm sure they're not. But you've got four well pharmacy, and I know it's dispersed across the landscape of the city, but there might be a corporate view taken from those four pharmacies. And I appreciate none of this is probably easy, but had we had more pharmacies or more variety, we might have got a fuller picture perhaps.
Yes, I would agree we would have done, but these were the pharmacies that patients had commented on.
Oh, right.
So
based purely
so
on
it's basically, everything is based on what the public have told us in from 1st of April 21 through to 31 of March this year.
Oh, I see. Thank you for that. You probably did say it, but I'm grateful for the reinforcement. So it's purely on the comments that came in from the patients?
Yes.
Okay, thank you.
Patrick.
Yeah, thank you, Chair. Just very briefly, and I know that the role of scrutiny is often to pick on the perhaps the negativity of the subject matter, but Tony, thank you very much indeed for Health Watch producing this report, but also to say thank you to the pharmacists who consistently have delivered, albeit there's pressures in the system, that particularly through COVID, the pharmacy system that we've had, there may be little hiccups from time to time, but it's a massive amount of service delivered on a daily basis to thousands of people, both in Plymouth and wider Devon. And I think it's important to recognise and thank those who have been under strain and stress in recent times for all they have done. And certainly over recent years, the range of services, particularly vaccinations being delivered through pharmacists, we've come a long way. And clearly the potential that's highlighted in Tony's report, but, with sufficient funding and with sufficient commitment from all stakeholders, could actually deliver an even better service to the public. So thank you for what you do, and hopefully we can all work collectively to see that there is extra resources to deliver even better benefit for the community.
Thank you. Right, so that leads us now to the next part of the agenda, which is David and Sue.
So if it's all right, I'm going to present to you, Mary, if that's okay.
I gather you've got
We've got
a
some
presentation.
slides,
That's excellent.
So what I want to do in responding to your comments is rather than apologise for trying to illuminate the situation and give you a candid view of what's been happening in pharmacy, hopefully give you some points of reflection as well. So if you can just pass on the slide, Elliot. So the context for this is just the Devon. We're the Devon Local Pharmaceutical Committee. We represent all community pharmacies in the Devon area. We've got 224 contractors in Devon, 55 of which sit within Plymouth. And that includes 2 distance selling pharmacies. The pharmacies obviously send things out by post, etc. We basically aligned around PCN networks, and where possible, we've got a nominated community pharmacist PCN lead that links with a clinical director in the PCN network to try and help support integrated working between the two. Next slide, if I could, edit. So I'm going to keep you going quite quick here. What we do, I know you obviously know about the supply side of things, and alongside that, we do quite a lot of work around public health, supporting people with their medicines use, and also things such as helping support medicines discharged from hospital. But what I wanted to just focus on here is the thing that isn't talked about very much, which is the number of consultations we pick up every day from the general public. So there's an estimated 1.6 million visits to community pharmacies. We've got about 38 million a year visiting us for advice for symptoms, which is about 730,000. In terms of each week, pharmacy teams provide advice to about 263,000 people, and that's for existing medical conditions. There's more than 58 million healthcare consultations by pharmacy teams each year. That's an average about 17 per pharmacy, and actually in Devon it's more than that. It's about 19 per pharmacy in Devon. So that's roughly, we believe, saving about 24 million GP appointments per year. We've noticed that that has risen in terms of a number of people crossing our path, and the acuity of the patients we're getting through the doors is risen since COVID, or during COVID. We're certainly seeing more complex situations than we previously did. In terms of, sorry, Alec, in terms of the current position, I think it's important that people understand the contractual envelope we're sitting within. So we're currently in the middle point, or just slightly past the middle point of a 5-year contract. That contract is flat cash, so it hasn't had a rise since 2019. In practice, that means real-term funding reducing year on year with inflation. Pharmacies have reacted really quite well to it. We believe they've made an estimated 37 to 50% efficiency gains. That has come by a number of routes. One of the key ones that's been done is moving a lot of the actual dispensing function to hub centres. So you see pharmacies sending a lot of their prescriptions away to be done in the central hub and then returning the following day. That's not true of all pharmacies, but a number of them now do that in order to improve efficiency. That does result in a reduction in the staff level in each pharmacy, because obviously it's an efficiency gain that we're trying to make. And it's driven really by that absolute need to reduce our funding envelope at a local level, because there's quite a few fixed costs sitting in the community pharmacy around premises, power, etc. Next slide, please, Elliot. So this next slide is I know you can't read it particularly well on your pack because it's all grey. But it just was a thing we did back in 2019 to try and understand what the implications for us were. We looked at the situation, and the line that's flat obviously is the funding coming back. If we didn't do new services, because to get that flat cash amount, we have to actually do a significant number of new services to take us back to that flat cash level. If you don't actually do any more than you currently did in 2019, you would see an actual drop in funding to the orange line. What we had intended at the time was to drive real integration in terms of in terms of actually aligning all our systems, etc., to outperform that, to try and get to the grey line. And we were hoping as well to get real integrated working going, involving PCN joint working, etc., to get us back to status quo of the orange line, which would have meant that we were pretty level. Our reality is we haven't achieved either of those objectives. We haven't managed to deliver even the average numbers of services, and we haven't got any PCN additional activity going through at this point in time, which means in Devon we're sitting really between the bottom red line and the blue line. So we're probably seeing a net loss against the 2019 figures, which you can imagine creates significant financial pressures into the system. And clearly, as we've now got inflation sitting in double digits, as Ian mentioned, the situation for pharmacy going forward could get quite grave. I wanted at this point, though, to talk about flow. We talked about efficiency, so I haven't got a slide on flow, and as it's come up quite a lot, I need to touch on it here. So the prescription flow is impacted by what I was talking about, hub and spoke. Clearly, that does mean there's potentially some additional time within the system. We expect, as a prescription comes into a GP practice, for them to turn it normally around within 1 to 2 days. And we would expect to turn that around once we receive it within 1 to 2 days, based on having to order stock, etc. That gives us roughly the 5-day turnaround that people tend to hear about. That's what normally drives that figure. If I hear what people are saying, you could get it on the day, you used to be able to get it on the day. That is still true. If a prescription comes through via electronic activity, and it's an urgent thing such as an antibiotic, that will be normally downloaded within the day, and certainly if a patient presents, that will be done that day, because we normally keep all that type of thing in stock. There is a significant difficulty, you're correct, Ian, in saying about the supply issues. We've seen quite a significant increase in out-of-stock issues that have to be managed by the pharmacy. And that actually takes quite a lot of time, because it often requires contact with the GP surgery for a medication change, or it might be about having to do something with as you were mentioning, with a tablet that's a higher strength in terms of having to reduce the size of it, or we prefer to do it the other way. If you've got lower strength ones, doubling up on those. So that is something that is an everyday occurrence these days, and it certainly didn't used to be. So again, that all builds into the pressure situation. They reckon we spend about 5.3 hours per week now actually resolving those issues. So it's certainly way above what it used to be in terms of those activities. Next slide, Elliot. I know this is going to be the beginning bit's a bit bleak, so bear with me. So in terms of workforce, we don't have a local school of pharmacy. The nearest is Bath, and we have got the lowest application rate to pharmacy university degrees in the country. We run about 10% of the national average of people, and that's demographically adjusted as well. So we run about 1/10 of the national average of people applying from schools in the Devon area into pharmacy degrees, which really doesn't help. There's a low uptake of pre-registration places in the area, particularly in community pharmacy. And the figures I quote here are for the Southwest. So you can generally read anything about the Southwest figure. It's likely to be worse in Devon and Cornwall than the Southwest figure, right? The Southwest figure for pre-registration places is 3.2 pre-reg students versus as a weighted average of 10.5% that we should be getting. So we're getting about 1/3 of what we should be getting in terms of pre-registration students. There's also a shortage of pharmacists and technicians. Nationally, we reckon there's a 400 to 500 pharmacist deficit in the Southwest. And again, the Southwest's got a vacancy rate of about 14%. And again, you can anticipate that being worse for Devon. I will, Chair, try and get you some Devon figures. I haven't had an opportunity to get them accurately for you today. National aspiration as well is to increase the number of pharmacists in practice and PCNs to about 7,000. Currently, it's about 2,600. So those are going to be a draw on pharmacists there. That doesn't take into account the additional roles that go into hospital and urgent care units, etc. So there's a significant increase in the demand for pharmacists, and that will be further exacerbated, as I'll explain to you in a minute. The thing I'd really like to draw your attention to is the bit at the bottom as well. We have really significant increased levels of abuse and aggression towards staff, and that's really beginning to impact on our retention and our ability to recruit. We are losing a number of staff now due to the experiences they're getting within the community pharmacy setting. People are leaving on that basis. The PSNC have recently come out and done a survey, and 75% of pharmacies now have experienced aggressive behaviour. So there is a real issue emerging regarding public attitude and abusive behaviour towards staff that is impacting on staff welfare. In fact, we've now got security guards going in. Boots have recently put security cameras on their staff in 600 stores. So that tells you that the indication of the issues we're now beginning to face into. Okay. So that all kind of paints a picture of us being under pressure. And PSNC surveys said 91% of pharmacies now experiencing shortages. Almost half those contractors are extremely concerned about their finances. 80% saying that the costs of running their pharmacies are significantly higher than they were last year. 9 out of 10 have seen a real massive increase in phone calls from patients about prescriptions. And that partly answers the question around phone calls, but you also need to factor in the fact there's less staff there to answer them. There's 86% reported a rise in requests for healthcare advice. So we've had a big rise in requests for advice, and actually an increase in acuity as well. 82% said there's increased workforce pressures, and we're getting a not coping score, which isn't really very desirable. So in terms of the risks, we've got a number of key risks that I think need to be thought about. We've got the lack of recognition going on with regards to financial sustainability. There's a real risk of financial sustainability that may impact on our ability to deliver integrated provision going forward because of the underutilisation of nationally funded services. It's worth saying or reiterating here that those services I talked about earlier that we need to get back to static levels, they're all nationally funded. So where we can actually utilise those, and they're often about things that can come that support other parts of the system, that funding comes from outside our local system. So maximising the utilisation of those is a really positive thing in terms of funding into our local health system. But clearly we need to have a reputation for being able to deliver them to actually achieve that. And inflation's clearly a real issue around financial sustainability. We worry as well about worsening recruitment and retention issues, and potentially the impact that might have on relationships. And also there's service level risks around localised system failure. I appreciate there have been closures, but what we haven't yet had is a domino effect where one takes another one down, etc. And our real worry is where that starts to occur, where we get not just one pharmacy closing, but more than one. And so that is something we think we need to be thinking about. Those hotspots themselves, though, we recognise give us a real negative perception of pharmacy that we wish to address. So we really think that, from our perspective, integration is a really, really critical thing to be driving forward with in order to start managing some of those risks. And I'm going to quickly run through a few slides, which aren't mine now. They come from, they were done about a year ago. They're Department of Health slides, but they show the intent for pharmacy. So, and if you just click on the next one. So there's a real intent now that the actual national commissioning teams for community pharmacy and for general practice sit with the same body now and sit with the same group of people. Their real intent is to drive integrated working. So this was written in 2021, and it looks to really change the way the community pharmacy contractual framework works to align it with PCNs. So there's a real willingness or intent to drive alignment around long-term condition management, to actually make our quality scheme relate very, very closely to what's happening in general practice. So it's focused around things such as hypertension, coronary vascular disease in particular, and it's really trying to make sure that we have that aligned piece, if you can go again. So you can see in the next slide those areas that they're trying to drive that integrated working. They're around prevention, they're around health inequalities, supporting patient access, delivering better outcomes for patients, and creating more sustainable NHS. All of this, we as a pharmacy system applaud. We really, really do applaud the integrated working, and we very much applaud the potential of getting involved in more and more clinical services. It's what we have developed as pharmacists to do, and increasingly the pharmacy course is moving more and more towards clinical interventions and patient care. So this is very, very welcome. Our difficulty is obviously the funding associated, and that is where we're having the issues. Next slide, please. And this next slide is historic. I have to say, this was again 21 slide. There are other bits now coming out that supplement this, but you can see the type of thing they were looking at the time, which was the Community Pharmacy Consultation Service, which is now obviously linked to the GPs as well. They're looking at linking that through to ED departments. They've extended the areas that we can do the new medicine service into other clinical areas. They've actually looking to drive contraception far further into community pharmacy so that we can have a much bigger role there. And they're looking at palliative and life services, etc. But they're now beginning to, and I'll go on to this in a bit further detail, and it comes back to your earlier point about how expanding services. They are beginning to look at, obviously, the expansion of community pharmacists as we move towards prescribing, what we can do with those things in the community pharmacy setting. And so you can expect significantly more work around the urgent care activity, around throats, ears, etc., to be part of that agenda. It hasn't been actually specified yet, but we're expecting that to come through in due course. Next slide, please. So the future is looking like community pharmacy trying to integrate across the levels in neighbourhoods, systems, etc. And that's the approach that we are taking. Next slide, please. Current performance. And I wanted to start with what was mentioned earlier about closures. We do have one of the highest rates of closures in the country. There's no denying that. I have to say that those figures quoted are historic data because we haven't had a recent set. It is fair to say that we are now seeing what we experienced a few months ago pretty well replicated across the country as things are going. It's great to see, isn't it? We're seeing other systems having very similar issues with increased closure rates. We have got about 1,000 hours closure per month, or did have in that last set of data. However, I just want to flag the fact that pharmacies are still open for 98% of their contracted hours. So what I find interesting is that, and obviously we don't condone the fact we're closed for 2%. The fact that 2% closures causes that much angst in the public should make people cause to reflect about the importance of pharmacy to the overall running of the system and the running of healthcare. And I just will ask people to reflect on the importance of community pharmacy in delivering care to patients, and therefore how far up should it be in people's mindsets about ensuring its resilience and ensuring we're delivering the most maximum possible out of it. Because I do question whether it is far enough up people's agenda. Service delivery is another one. It's interesting to state, I said we were underperforming on services, that the new services are really the discharge medicines and the CPCS, and they are high volume, high value services. So it's really important that we do deliver on these. They are ones that we don't have direct control over because they're referred services. And we are underperforming by about half on them, and that is having a material effect on financial sustainability. The services that we have in our own control, however, we do perform very well on. So blood pressure, lateral flow testing, new medicine service, we're outperforming national statistics on all of those. So I think it should be applauded for that. And the blood pressure service in particular has a massive opportunity in actually impacting wider system health. Flu is another one. Just so you're aware, we did deliver 124,000 flu vaccinations last year in Devon. what's changing, and hopefully we can change to a more positive light now. So there is a lot going on in the workforce. Sorry, can we go to the next slide? I'm sorry. So, as has been mentioned before, workforce is the critical issue, as David was alluded to. We do have a critical issue around workforce. We are responding to that, though. We are developing cross-sectional roles around technicians. We have got a more system-driven approach, which will actually dictate where some of those pre-registration students going forward. So that should help our situation and ensure that we fully populate pre-registration students. Bath University is looking at approaches to increase their flow of students. And we do have Health Education England looking at the options to improve undergraduate provision. I can't say too much more about that at this point, but I'm hoping we shall have some positive news for you within the next few months. We're driving recruitment through Proud to Care Agency, etc., to try and go out to schools, to try and encourage people to come forward. And pharmacists are becoming prescribers. So 24-25 should see the first output of pharmacists from universities with prescribing qualifications. And we are retrospectively looking at the legacy workforce to upskill those into becoming prescribers as well, at which point we will be able to massively enhance what we can do in the community pharmacy setting. There's greater, I think, recognition of the potential of urgent care, and Daffod's just disappeared, but we are working with Daffod around the urgent care agenda, and there's massive opportunity to potentially support around that. So I've alluded to the fact that some pharmacies are under a lot of pressure, but on a survey recently, we know that the great majority of pharmacies still want to deliver more services. So there's a real opportunity to grab that urgent care agenda and support our practice colleagues in actually seeing patients and delivering care. Service growth. There is a real acknowledgement, I think, by NHS England to see the growth in services. We're about moving towards 20%-ish, maybe moving a bit higher than that now in terms of activity and value. In Wales, it's 50%, so you can expect to see that service side of pharmacy growing and growing, and that's where the comedian's up there. Pharmacy is going through a radical change in its shape and appearance. PCN leadership are there, and they're supporting clinical directors in their delivery. Next slide. So there is huge potential. There's huge potential improving prevention, inequalities, etc., and improving primary care access by utilising our existing services such as the GP Community Pharmacy Consultation Service, which allows GPs to refer on to us lower acuity patients. There's also ability to deliver better outcomes for patients and medicines by massively expanding on the new medicine service, which allows us to make sure patients understand their new medicines and supports them with those initial few weeks when they're most likely to actually not take their medicines correctly. Also, discharge medicine service, in a similar vein, helps support patients to understand what's required in terms of medicines use after they've exited hospital or another care setting. We know that that service has a really very significant effect on readmissions and has a very significant effect on numbers of days bed stay in hospitals. So it is really, really very value creating as a service provider. Efficiency and effectiveness. What I haven't mentioned in that issue of supply and the way that the supply runs through in terms of a medicines protocol is we have something called the electronic repeat dispensing service. Now, that allows us to have on the system prescriptions for people for 6 or 12 months. Therefore, they don't need to go to the GP practice. They are done automatically. They are loaded into the system. And they allow the pharmacy to pull down those prescriptions in good time. And in those circumstances, we really, really applaud that use because it really starts to get at that concern about medicines not being ready, because they will be if electronic repeat dispensing is utilised. We don't utilise that enough. There is a great potential there to improve efficiencies both for pharmacy and for practices by maximising that utilisation. And also just make there's this massive opportunity as well in terms of expanding services and that prescribing function that we can potentially utilise very significantly at a local area. And the reason we can do that is that commissioning is changing. Currently, commissioning is done by NHS England or Pharmacy Services. That is about to move to the ICB. So they will then have responsibility for community pharmacy commissioning. That gives us great scope to drive integrated working and to mould this in the way we wish it to, and to provide, expand the capabilities that we wish to offer through it. So there's a really, really major opportunity with prescribing all those other things to actually mould community pharmacy to deliver more provision. And ideally what we wish to do is to make life easier for patients. So when you pick up your medicines, act as the medicines checkpoints, so we can check your blood pressure, etc., so those additional points of contact aren't required, to make things slicker and the whole system efficient, more efficient for us and for the patient. And actually provide more joined-up care. Sorry, next one. And in the short term, those services that we talk about have got really big opportunities. On average, if you looked at the things in Cold Day, I think 12,500 appointments per annum could potentially, from a PCN, go to community pharmacy through consultation service. That's a very high estimate, and you never reach that level, but it is a substantial number. Discharge medicine service, as I've mentioned, 10 consultations of that prevent 1 readmission and reduce bed days. The new medicines service, we know that improves concordance and reduces medicines waste. And the blood pressure service, we know can have a major impact, and particularly if we work with the GPs to flag and work on the patients they already have concerns over, we can make that have a real benefit to the system. And ERD I've already raised. Next slide, please. So what we've got is very much a curate's egg, but we need to do 2 things. Firstly, we need to enhance the robustness and sustainability of the pharmacy system. But alongside that, there are many, many opportunities in the pharmacy system that are available to enhance capacity, drive efficiency, and improve patient care. And as we have a lot of our system is actually robust and can flourish and can drive that on behalf of the system. But we do need to recognise we have got pockets where there is severe stress, and that we need to ensure that they're robust, and we have got effectively contingency plans where things aren't in place. Next slide, please, Elliot. So what do we need to do? We need to get greater system engagement, particularly relating to primary care development, and actually probably relating to the strategy as well, because at the moment the primary care strategy is primarily focused on general practice, and it would be great to think about going forward, thinking about a more integrated approach. We need to recognise and respond to the challenges in the wider system to create some more robust support processes. We need a robust workforce strategy, and we're beginning to work that up on behalf of the Integrated Meds Op team. And we're trying to work up a robust piece that allows us to have a more attractive place in community pharmacy for people to work. A clear development to local plans as well around how we enhance the resilience. And we need really investment in thinking about how we drive integrated working through systems, workforce, and joint services. And importantly, really importantly, we need improved communications on expectations to patients, as I think a number of you mentioned today, because there's only so much we can do in the short term, and we have to reflect the fact that the pharmacy system is significantly pressured. Next slide, please. And this is just a thought from Walt Disney to end, which is the way to get started is to quit talking and start doing. All right? Okay.
Thank you very much indeed. Okay, I've got Patrick first, then Viv, and then Ian. But I would ask you all to remember, I want to be out of this room at 5 o'clock. So, and we've still got exempt business and the rest of the agenda. So can I just ask you to be concise, please. Patrick?
Thank you, Chair, and thank you, David, for an excellent presentation. There are just 2 points I wanted to tease out a bit more information. One is on the supply chain arrangements, and do pharmacists have their own supply, or does it come from a central hub? So just a bit of an understanding on how medicines are stored and supplied to the individual pharmacies. And the second one, more substantive point, is really on the discharge medicine service, and the fact that, you know, here in Plymouth we've got issues at Derriford. Some of those issues are that patients on discharge wait many hours for prescription to come from the central pharmacy, and Derriford themselves have had issues with their own pharmacy. So are we using community pharmacists now, or is this an aspiration for the future? If it's something for the future, what can we be doing to expedite the use of community pharmacists in discharging patients more quickly from Derriford? So those 2 points, please. Thank you.
Okay, so from a supply perspective, there are 5, maybe 6 wholesalers. There are 2 or 3 really common ones that everybody uses, and then there are some additional smaller ones that individual pharmacies may or may not use. But the reality is that there are occasionally some sole wholesaler out-of-stock issues, but quite often they go across fairly quickly once they start going out, because obviously you duck and dive to try and get the stocks. And the other thing just to be aware of is some pharmaceutical organisations have direct relationships with their particular supplier, so you may only be able to get that product from one supplier. In some instances, you can only get that product if you contact the manufacturer and give them details of the prescriptions, because supply gets tight. So I think it's under-recognised the amount of effort that goes in sometimes to secure supply, because sometimes it can get quite convoluted. And on the other point, DMS, DMS is active. We have got it active at Derriford. We are not using it to full extent, but where you see the real maximum use of that, they often have integrated systems where we haven't got that at Derriford. The new chief pharmacist there is working with us on that. We're about to have a presentation actually about how we might expand the use of that provision. He is expanding it, yeah. So we have great hopes, in particular in the Derriford situation. He's been more proactive than others. So we should applaud him for that. And I think we will see significant increase in that utilisation in the Derriford location.
Okay, thank you. Perhaps in our work programme at some point in the next umpteen months, we might want a report from Derriford on how that's working, Chair.
Certainly, thank you. Right, Viv.
Thank you, Chair. First of all, could I apologise about my phone? I did switch it off, and the second time
it's
David switched it off, and it still goes, and they tried it in the members' room. We don't know why it still goes, but it's switched off. But I do apologise. I will leave it in the pigeonhole next time. I loved your presentation. I love the pictures. Please, can you just tell me, is that a comedian?
It is.
It is. Lovely. Thank you.
Frame them.
Yeah, it's beautiful. He's beautiful. I had one on my hand once, and so that's lovely.
Thank you very much. Okay, right. Can I have a question, please, about pharmacies from Ian?
Well, almost anyway, Chair. David, you've not lost any of your enthusiasm. We had this conversation perhaps 5 years ago.
Well, maybe, I think we did.
And
yeah.
I'm really impressed that you're still so enthusiastic. I hate being negative on this, because I know how hard you work to drive forward the service and to support GPs and support the public. So, but I do have a problem with these pharmacists who seem to be working non-stop. I mean, when I go to a pharmacist, the actual pharmacists are grafting because they're constantly working, and then, you know, we want to ask them for advice, and it takes 10 minutes because they're in the middle of something. So
yeah,
I understand you're going to have a different commissioning service, and that may ease a lot, but you've still got this major problem with workforce availability. And I don't want to sound negative, because I absolutely love what you're trying to do.
Yeah.
But I do have them concerns.
And I think, you know, that is justified in some locations. Others have got more flexibility. It depends really on how you reform and remodel your workforce within the location. But it is fair to say that actually it is pressured, and particularly coming into flu season when we're going to pick up flu jabs as well. But the thing about the GP CPS service and others means that they're actually booked appointments, and so you put them into a slot of the day that you think you're going to be less busy. And that's what we're increasingly thinking about how we have to do things, is to how you'll manage your workload. I talked about ERD earlier on. Why that's really important for us is that all those things come down in set ways and we can manage our workload. So having that all stacked in the system in a planned way really makes a profound difference to us. And managing, making us as efficient as possible is really, really critical going forward, so that we can free ourselves up to actually do those interventions.
Thank you. Thank you, Chair.
Natalie.
Yeah, thank you, Chair. Mine is question is about the recruitment. You're saying about the university at Bath and the fact that obviously there's a limit. You know, you're not getting the numbers through. So the question is it about the quality of Bath University's pharmacy department as such? You know, because obviously students are savvy about where they go and you know, where they're more likely to get a job if they go to X, Y, or Z university. I don't know where Bath for pharmacy is, you know, scattered. Or is it more about, from a southwest perspective or from our area perspective, in terms of our students, prospective students going there, is that we've not got the quality of the students, shall we say, in terms of the qualifications academically that they need in order to be able to apply to go. Because obviously, ideally, what we want is young people from the southwest applying to Bath and then coming back and being in the southwest, not, you know, rather than this age-old thing we said already about GPs, where we're trying to attract people that may qualify somewhere else, and then we're trying to attract them down. We want them to stay within our area. So is there a reason?
I could probably spend an hour talking to you about this. There's a number of factors, but Bath are actually a really good pharmacy school. So they tend to, we have a system that actually grades all pharmacists when they've qualified, and they then get a choice of their pre-registration placement depending on that grading, and it's a long list from 1 to 1,000, whatever. And the ones at the top choose where they go. Bath students tend to be high performers. They tend to choose acute trusts as pre-registration places. So we get, obviously, our primary issue with pre-registration places is community pharmacy, not acute trusts. They tend to fill. So we tend to be bringing them in from elsewhere. So that is part of our issue. Bath, being fair to them, are doing a lot of work with their students around placements in the southwest to try and encourage them about where it's coming into our area. But clearly they're high-performing students. So Bath are really, really being proactive in supporting us, but clearly there's an issue there. We had a big discussion about international students yesterday. And I need to be honest about this, is that the demographics of Plymouth don't necessarily help us in terms of the spread of what we got, and particularly the spread of the pharmacists. And it makes it a less attractive place for people to come. But there are a number of other issues. That the fact we don't have applications going into pharmacy undergraduate places in the first place is really not helpful. And that's our first point of action, because only when we've got those applications can universities find themselves in a position that actually makes sense to actually drive here. And then from that, hopefully, we'll start to create greater numbers of people. But we're also trying to work through the techs, pharmacy techs, because they are also now a profession and they're qualified separately. And we are trying to do work with them about thinking about how we encourage them to the area. And actually, both of those, we're looking at rotating people through acute trust practices and community pharmacy to make people flexible across the system, so we can create real flexibility in how we utilise people at a local level.
Right, thank you very much indeed. We'll take the recommendation about Derriford and the prescribing, etc., coming through and how you get people out of hospital quicker, etc. So we will take that forward. No, I'm not going to take any more at the moment. I need to move on. And David and Sue, can I say thank you very much for trying to explain the complexities of how pharmacies, etc., are working and in Plymouth, and I think that's been really, really helpful. So thank you both very much indeed. Now, folks, I'm going to quickly move on and say tracking is all up to date. The work programme will be looking at public health indices and winter preparedness. And now I'm going to say we move on to part 2 of business, exempt business. And so we need to say to consider passing a resolution under section 100A brackets 4 of the Local Government Act 1972 to exclude the press and members of the public from this meeting for the following item of business on the grounds that it involves the likely disclosure of exempt information as defined by paragraph 3 of part 1, schedule 12A of the Act as amended by the Freedom of Information Act 2000. Okay, so I need a proposer for that. Thank you, Lee. Seconder, Patrick, thank you. Put to the vote, all agreed. Right, so I need